My name is Amit Kochar. I am honored to have with us today for our Pacific Neuroscience Institute webinar Dr. Linda Lee. She is on faculty at Harvard Medical School. She's a facial plastic and reconstructive surgeon and affiliated with Massachusetts Eye and Ear Infirmary. She's the Associate Chief of Plastic Surgery of the Harvard Vanguard Medical Associates. I've had the honor and pleasure of knowing Linda since I was a fourth-year medical resident or head and neck surgery resident at Johns Hopkins when she was doing her fellowship in facial plastic surgery, arguably the best facial plastic fellowship in the country, where she came after she completed her residency at Massachusetts Eye and Ear Infirmary, and where she returned to after completing her fellowship. Dr. Lee has trained in Texas, Boston, Baltimore, and has traveled the world lecturing and teaching. And we're grateful to have her share her expertise with us today for our patients who suffer from facial paralysis. I think we're all going to learn something, including myself. And just as a side note, this is being recorded. So we ask everyone's permission to be recorded. And from a HIPAA standpoint, we're going to be protecting everyone's privacy. Anyone's names who show up in the chat for questions at the end of the presentation will be removed when we replay the video and share it online. So if anyone would not like to be recorded, I'd ask you to please leave the lecture. But if you're okay with that, please continue and stay and listen and learn from Dr. Lee. Thank you, Linda. I'll give you the stage.
Thank you so much. This is, I'm so happy to be here. Normally when we're giving these talks, it's to other providers. And so it's such a pleasure to be able to speak to patients and people that can kind of directly benefit. So this is one of my favorite topics, and it's treating facial paralysis with facial filler. So we're going to talk about today kind of a guide from a patient perspective. I have no disclosures. So just to tell you a little bit about my background, like Dr. Kochar said, I'm from Houston, born and raised, and I was actually a chemical engineer in college. And then after medical school, moved to Boston, couples matched with my husband, who is anesthesia. And the one thing we said when we were matching is, I don't really care where we go. I just want good training, but I just don't want to go to the Northeast because it's too cold. And then one thing led to another. We love the city, love the program, and now we've been here for 15 years. So this is a view from my office on a good, happy summer day like today. And then this is a view of the office for like 6 months out of the year when it's freezing cold. Still beautiful, but definitely freezing cold. So like Amit said, then after residency, I went to Hopkins for fellowship. And this is a picture of the famous Hopkins Dome. As we are driving away from Baltimore to go back to Boston on my last day out of the side view mirror. So I think a lot of kind of what we fall into, what we end up doing is kind of random and a lot influenced by who we come into contact with, what you've been exposed to, and what clicks with you. So I did my residency at Mass Eye and Ear, worked with Dr. Tessa Hadlock, who, as many of you know, is like amazing and has dedicated her whole career to advancing treatments for facial paralysis and kind of making surgery as beautiful as it can be in the whole big picture. And her enthusiasm is so contagious. And so it's hard not to see how amazing working with facial paralysis patients can be. And then I went to Hopkins and I worked with Dr. Patrick Byrne and Dr. Kofi Bohaney, who also see a ton of facial paralysis patients and just love it and are always passionate. And between the three of these people, it just kind of showed me how amazing these surgeries can be, how amazing treatments can be, big and small. And it's just how much you can improve the life of a patient with facial paralysis. So how I kind of got into this specific topic is I do a lot of cosmetic filler in my practice, but for facial paralysis patients, I was still doing a lot of autologous fat transfer and dermal grafting and more surgical procedures, mostly because of insurance issues. So filler, unlike Botox, is not typically covered yet for patients with facial paralysis. So I would every now and then have a patient with facial paralysis who would just pay the cosmetic fee for filler and get essentially facial paralysis filler. And I just saw how easy it was, how gratifying it could be. But there's no evidence really on using filler for facial paralysis. So that's kind of what started this whole research idea for us. So filler for facial paralysis to me is very different than cosmetic filler. So I'm going to show you some examples of the difference. So this is one of my favorite patients. She is a nurse at MGH, which is our hospital, and she works in postnatal care. So she uses her mouth all day to speak to patients, kind of coaching and talking to them. You can see in that top photo in the right lower lip, she has a little volume loss, which is from disuse atrophy. So just not using the muscle kind of makes it atrophy. And that volume is so small, but because of that area and where it is, it's difficult to fully close her mouth. So she has a little bit of air escape, particularly with words that are plosives, right? P's, B's. So Boston, breastfeeding, baseball, like those words are all, they require you to close your mouth fully. And if you get a little air escape, it just changes things. Also, liquids would drool out of her mouth just a little bit, but enough that it required a lot of effort to kind of keep things from falling out. So you can see in the bottom photo, just a little bit of filler in a single treatment does a beautiful job of closing her mouth, letting her speak better without air escape, and making the liquids and the food not come out of her mouth with less effort. So I think it's just such an amazing treatment that for the right person in a very specific patient. So I'm just going to say the concept of functional or reconstructive surgery that overlaps with cosmetic procedures is pervasive throughout all of what we do. So a lot of facial plastic surgery. So I'm going to show you just a lot of different examples of things where the idea of reconstructive and cosmetic overlap is not new. Okay. So this is called DFC rhinoplasty, meaning dual functional and cosmetic. So take a twisted nose, a broken nose, a crooked nose, an I can't breathe nose, deviated septum. And then while you're in there, make it look straighter, make it look more symmetric. It has both benefits of like function and form. I love this slide. It's an Andy Warhol creation from 1960. It's at the Whitney in New York City, and one of the residents sent that to me, and she said, "This reminds me of you." So the idea that even from the 1960s permeate to today, where subtle changes in facial symmetry, facial harmony can just affect the way the world views you, right? So in the case of like rhinoplasty and crooked noses, bringing the nose into balance takes an overpowering feature and focuses everything back on the harmony of your face. In facial paralysis, subtle changes to your face can make it more symmetric and just make it different what people see. So this is again functional septorhinoplasty. This is purely insurance, right? Functional, make it deviated septum go back to the middle, make you breathe better, but it has this secondary effect of being more symmetric, which is kind of aesthetically nice. The bottom picture is her septum, which should be a straight, piece of cartilage, and instead it's literally fractured in half. So I love this kind of form with a second, like the improvement in function, which gives a secondary benefit of symmetry. Upper blepharoplasty is one that we know actually in facial paralysis. You can have trouble seeing, you have extra upper eyelid skin that kind of hoods your eyelashes. And then you just take a sliver of skin out and all of a sudden you can see better. It's more aesthetically pleasing, but it's done for vision. And that is done a lot in facial paralysis covered by insurance. Facial fractures are something that we do that are kind of like a extreme version of this. I think, you can fracture your cheek, fracture your midface, and there's not a lot of functional deficit associated. There's not a lot of things you can't do medically if you have a facial fracture. But if you don't plate it and fix it, you will have a facial asymmetry or a contour deficit. So this is another surgery that's kind of done for medical reasons that has a aesthetic side effect. This is a very dramatic one, right? So this is a patient who has lipomatous masses, just like lumps of fat that grow for no reason, and they kind of collect everywhere. They are benign, but insurance lets us remove benign lumps of fat and remove all of the stuff, and it's aesthetically nice. He feels literally a weight lifted off of him, but it's for a medical reason. And then the last one, which is I think the most dramatic, is nasal reconstruction for cancer, which is dual functional and cosmetic, quote unquote. It's all insurance, it's all medical. This is one of my and Dr. Shea's favorite patients at Mass Eye and Ear. And she has had nasal cancer treated with radiation and surgery. So she's cured. She will live a long and healthy life. But how can you live like this? So we have done for her reconstructions, multiple surgeries that involve taking bone from her skull, cartilage from different places, skin from her cheeks, skin from her forehead, and reconstructing a new nose for her. And she's had multiple surgeries. And let's say that we wanted to keep doing surgeries and do tweaking, they would all be covered by insurance, no question, because it was related to cancer. So I think to me, facial paralysis is the same in that it's a medical condition, which should allow treatments to be considered for patients in anything that we think medically could benefit. So now we're going to get to the meat of like filler and the differences. So I'm going to show you some photos of cosmetic filler, and then I'll show you some kind of functional filler, facial paralysis filler, and I'll tell you the similarities and the differences in my mind. So I pulled all of these from my Instagram so I can make sure that they are photo ready and able to be shared. So this is a cosmetic filler, right? It's just old volume loss from aging. And she has a lot of lines in her lip. It's very thin, not a lot of pink lip is showing, which is just a normal volume loss age-related process. And then a little bit of filler makes it softer, a little younger, but you can imagine you can close your mouth a little easier because you have more kind of soft tissue. Another just totally aging face, wrinkles around the mouth, the quote unquote smoker's lines in many people who have never smoked. But just you lose volume and it starts to kind of, your lips start to kind of fold under into your mouth. And then just like cosmetics, Botox or neurotoxin and filler can be used synergistically. So there's a lot of different things we do cosmetically with the lip flip. You can make the gummy smile a little softer. So similarly to facial paralysis, we think about what can we do with Botox or neurotoxin, and then what can we do with filler? And neurotoxin is more affect your muscle, affect synkinesis or twitching. And filler is a physical product that gives volume, restores volume loss, or fills divots, right? So back to our lady who has this little volume loss. She just a syringe of filler right into that right lower lip kind of makes everything plumper, and now she can close her mouth. So that's kind of functional and cosmetic lip. There's this one is a cosmetic marionette lines, nasolabial folds, just wrinkles around the mouth, the quote unquote puppet lines. So we do filler in the office, upright, and it doesn't make them gone. It just makes it softer, right? So less dramatic, less kind of old looking, and just a little bit smoother. This is a facial paralysis patient with the same area, that nasolabial fold. This patient calls it scrunch face. So she just, a combination of maybe synkinesis and everything just makes her lift that side so heavily. Botox helps, but too much Botox makes her drop her lip. So we can't do too much Botox. And so filler just makes it softer and makes it look more symmetric. And she doesn't care at all that it's age looks old, that there's a wrinkle. She just doesn't like that it makes her look mad or mean or upset. So I think it has a symmetry improvement, but also it helps to make it softer and less angry looking. In her, you could do a fat graft or a dermal graft. So we started with filler, but we'll talk more about the differences between grafting too. This is a patient that was done pretty recently where she has, from either surgery or disuse atrophy or scar, a little hollow area at her right eye in that temple. So it's just filler makes it more symmetric. So if you look at her, it's very subtle. But to me, the difference is when you look at the person on the left, there's something. It's facial paralysis. You can't quite put your finger on it, but there's something that's not symmetric. And then in the picture on the right, it just looks quote unquote normal, like much more symmetric and normal, where you just doesn't draw you to look at that area. So I think the great thing about filler is you can treat all different areas, just like in cosmetics. You can treat the lip, you can treat the midface, you can treat the eyes, you can treat a scar, and you can kind of look at what the patient needs. And not every patient is the same, just like in cosmetics. So the normal, the old school, like the thing that is covered by insurance is surgical grafting, meaning take fat from your belly or your inner thigh and liposuction it, spin it down, centrifuge it into tiny particles, and then inject it into areas of the face where you have volume loss. So the beauty of that is it's a permanent result, right? You put fat in, you put a fat graft in, you put a dermal graft in, that's permanent, which sounds amazing. But there are times that you don't want something to be permanent. So number one is filler is temporary. It lasts about 6 to 12 months, sometimes up to two or a few years, depending on which filler. But for patients who have an evolving facial nerve status, you don't want something permanent. So whether it's bells or a surgery with kind of stretch injury to the nerve, or anything, right, where you are hoping and expecting that you will get some recovery, you don't want to go in and do something that's permanent. And it's nice if you put filler in to kind of help with temporary things, and then it recovers, it will go away, and then you can titrate. You can put less filler in next time. You can not do filler again. Filler is reversible. So we use hyaluronic acid fillers. There are many different kinds, but they dissolve on their own in general. But there is an enzyme called hyaluronidase, which we keep for emergency reasons. And if you don't like it, if you have a problem, which is very rare, or if you have some change in your status and you need to dissolve it out, it is reversible, which gives us some safety. One of the biggest things that I love is everything in facial paralysis is affected by positioning. And, if you're doing something sitting upright, this is how you speak to people. This is how you want to see gravity have its effect. So everything grafting wise is usually done with the little help of whether it's twilight or anesthesia. It's done lying down. So when you lay down, it's different, right? So especially in Our Lady with the lip, if you're doing it awake in the office, you could put a little filler in and have her say baseball, breastfeeding, Boston, see if it closes the gap. If it's not, do a little more. If it still doesn't do it, do a little more. In surgery, there's many things that are not as optimal. One is you're laying flat, so you're not affected by gravity as much. Two is if you need to put some lidocaine or novocaine in for the surgical procedure, that can immediately affect your ability to speak. So your numbness can change, or that lidocaine can give you a little swelling, which then makes the picture different. Another reason is some patients have their facial paralysis related to another surgery. So whether it's parotid cancer, it can be an acoustic neuroma surgery, it can be brain surgery, it can be a stroke, right? It can be Bell's palsy. It can actually be related to a really rare thing that happens after facelifts. And so for whatever reason you have your facial paralysis, some patients are not ready for another surgery, either mentally or medically. And the idea, even as small of a kind of local procedure, even under twilight, some patients just are not ready to go back on the OR table. So filler is something done in the office. It's 10 minutes, right? And it just feels like such a less of a big deal. Literally from I don't need a ride home. I can drive myself. I don't need to fast. I can just eat. Everything about it is just less intimidating. And then my favorite, which is as a surgeon, is filler can be done as a trial before surgical grafting. So there's often patients where either it's surgical scar or there's been some radiation, or, whatever it is, we're not sure we can get an improvement. If it's too stuck down, or let's say we do something and you don't like it, then we get a trial. So number one, you're putting filler in. I can do that as a test to my own kind of ability to expand an area. What plane do I put it in to get the best result? Does it work, right? If some radiation is so stuck down, I can't get it out, then that's good to know. So it's almost like it gives you a trial technically to see where do you get the best and most symmetric result. Whereas with fat, you can't have that trial. So this is Jess. She's our research coordinator from a couple of years ago. It was amazing. She is now in medical school, but she was interviewing these patients and kind of talking to them. And as we're doing pre and post filler surveys and studies, she said, I really feel like patients benefit so much from a psychosocial well-being standpoint, right? Like this little bit of filler may seem like not a big deal to us, but it just makes such a big difference in some people and their mental health. So we decided, let's study that, right? So we looked through the literature, not much is there. We know we need something that's more than just people telling us, oh, it's great, because I want an objective, validated survey that I can give to people. And then facial paralysis patients are varied. The etiology of your facial paralysis can come from pregnancy, can come from bells, can come from surgery, can come from, all Ramsay Hunt. So we have to find an instrument that has been validated so we can apply whatever results we find to all facial paralysis, from private practice, academic centers, different people. I want it to not be just our patients being like, oh, this is great. So we found validated instruments that are based in cosmetics because there's nothing for facial paralysis. Then we added facial paralysis specific questions after interviewing many of our own patients before and after, what matters and what changes are made. So we published this paper. This is Adib. He's one of our residents that's going into facial plastics next year at Hopkins. Jess, and then Carrie Shanley, who's our awesome PA, who does a lot of the Botox and filler for functional patients for facial paralysis. And we showed that dermal filler treatment improves psychosocial well-being in facial paralysis patients. So a single treatment, we did a survey immediately before and then 2 weeks after a single filler treatment. And patients reported improved symmetry, as well as improvement in psychosocial health. And there were 4 additional findings, which I loved. So number 1 was patients felt they could more accurately express their emotions to others. So this is something we kept on hearing from people, meaning I think when you have facial paralysis, sometimes when you meet a stranger, you feel like there's a moment where they're trying to figure out what's wrong with, is there something not symmetric? And whether it's true or not, right? This is something patients feel. So if you make something a little bit more symmetric, it makes you feel like you can more accurately express your emotions because they're not trying to look at your face. They're just listening to what you have to say. Or you don't look as upset like our lady with the scrunch face. Number 2, which I think was so powerful, is patients were less worried that other people would think they suffered a stroke. And so, facial paralysis can come from a lot of different etiologies, including stroke. But I think that if a little bit of any treatment can make people feel less worried about looking like they had a stroke, that is extremely powerful. This one I love just because of the time period that we're living in. So patients were less likely to avoid photographs. So I feel like, especially in the period of Zoom and FaceTime and COVID and social media, how comfortable you are in a photo speaks volumes about your comfort, just your comfort level with your face and confidence. So I had a patient who had facial paralysis. She has a grown daughter, and she would never take photos. She was like, I hate them. I just hate being in photos. I feel like I ruin them, all these things that were not true, but she said them. She felt them. And then one day her daughter said to her, after you go, your granddaughter will not remember you because I don't have any photos of you. So obviously, after that, she put herself in photos and she was like, I get it. Like, I'm going to put myself, but I really want people to not hate photos. And so if there's anything we can do to just make you feel more comfortable in that photograph, that is so meaningful to me. And then the last thing, which is my personal favorite, is that patients reported significant improvement in personal confidence levels. So, I mean, to me, as a facial plastic surgeon, this is all about what we do. This is our whole goal in life, in our career, is just to make everybody feel more comfortable in their own skin, more confident in whatever way, with any surgery we do. So I love this one. So the problem is, in many cases, insurance coverage, right? So strangely, surgeries are covered. You can do one autologous graft, fat graft, you can do dermal grafting, you can do two, you can do three. They are covered without much problem, but filler is not covered, right? So we said, let's do a cost analysis, right? So here's Jess, and then Lauren Miller is one of our awesome residents who we looked at what is the cost comparison, and is this a treatment that should be considered under insurance. So we called it cost-conscious decision-making, facial filler or surgical grafting for facial paralysis. So we used the lip as an example because the lip in our study was the most common area treated. The most common volume treated with filler was 2.3 cc's of filler. So we compared a 2 cc dermal graft with Medicare and Medicaid to 2 cc's of filler. And after looking at just the cost of filler and the cost of one dermal graft, the break-even analysis is that you could do about 6 or 7 years of annual filler injections to be equivalent to a single grafting procedure. So we as surgeons know that when I pre-op you for a fat graft, I tell you, I'm going to put in 100% of what I think you need. And then I expect normal fat atrophy. So you are expected to have 90% survival of this fat graft. That's normal. So if I try to put 110% of what I want to account for that, sometimes all of it dies because you can have necrosis and it's just too much for the blood supply. So we plan in a staged way. We're going to put in 100% of what we need, and then we will let it heal, atrophy, do its thing. And then we'll come back a few months later and we'll do a second procedure and fill in the rest of it, right? So sometimes people need 2 or 3. So that break-even analysis is likely even underestimated because it doesn't account for multiple fat grafts. Then just financial things aside, it doesn't account for anesthesia. Our patients have medical comorbidities. We use Medicare and Medicaid to kind of consider it, but private insurance probably reimburses more. And then patient recovery. There's so much that goes into time off work and kind of those things that are around recovering from surgery. So our conclusion is, after each of these studies, filler is not some crazy, overly burdensome, ridiculously expensive treatment. It should be considered for insurance coverage in some cases, right? Not in every case, but in the right patient. It is not unprecedented for filler to be covered by insurance. So in 2009, a law was passed that filler can be covered for HIV patients if HIV lipodystrophy, which is that wasting fat loss, if lipodystrophy is associated with HIV, and if lipodystrophy is a significant contributor to depression. So if mental health is a factor caused by lipodystrophy, then you are allowed to use filler for a medical purpose. Okay, so we treat these patients. We see someone with HIV lipodystrophy. We request filler from the insurance, just like we do with Botox. There's paperwork, just like with medical Botox. And then they send us the syringes, whatever we need, and we treat it. Importantly, HIV medications have come a long way. So actually now a lot of patients don't have severe lipodystrophy anymore. And actually facial paralysis can be much more obvious in some patients. But that law for HIV was not passed until 2009, after enough data was available to show that filler really helped these patients. So we feel the first step, obviously, is doing these studies and showing objectively how much it can benefit people. And then once we get awareness of all that, now we can fight for insurance coverage. So interestingly, a lot of these HIV papers show that for one face, some patients required 26 syringes of filler. So I think what we need for facial paralysis is so much less than that. We'll see. But I think it's even much cheaper for facial paralysis than for HIV. So this is a very, I think, timely, relevant discussion, and the right time to be kind of having these thoughts. So CNN recently highlighted our studies, right? This is like, there's a show that I had never heard of until they interviewed us, but it's called Skin Decision on Netflix. And it talks about the overlap between functional, reconstructive, and cosmetic surgery, and how there is a gray area, and it's not always black and white. So the show looks at like people who have had trauma, car accidents, and then they have their life-saving medical procedures. And then they're left with a terrible scar or something that's from the trauma. But after you leave the ER and you show up with the trauma, it's not always covered by insurance anymore. So it's kind of looking at that side of things. So our study fell right into that discussion, and they interviewed our patient to talk about how cosmetic filler could be used as a reconstructive procedure to help with a medical condition. So she gave the most beautiful quote. She said, "I could cry because I could not believe how much getting that lower lip firmer helped. I ate better, I spoke better, and I was much more comfortable. It's physical health, but it's also mental." And I just thought that is the most beautiful way to encapsulate everything we were trying to do with this study, with our treatments, and with fighting for insurance coverage, that it's just such a beautiful way to encapsulate that. So there are important differences between cosmetic and functional filler. So this is a picture of our beautiful PA. She's awesome. She's doing Botox. So the difference between cosmetic and functional, the biggest one to me is numbing. So for aging face, for kind of making things younger, we want a painless experience. So you can numb with lidocaine, Novocaine, numbing cream. We can really make it a painless experience to where you're like drooling and like you can't control your mouth, but it doesn't hurt. So I would say facial paralysis patients often, if we numb you, you lose mobility. Like, so if we're trying to treat your mouth and I numb your mouth, all of a sudden you're drooling and I can't tell what I'm doing anymore. So I will often tell facial paralysis patients, explain that, right? And then they just say, okay, fine, I'll put some ice on it and try to make it as numb as I can with this. And I'll hold this thing that distracts me and just go for it. There are some patients that are like, no, I need numbing. And in which case we just like mark it very carefully and try to look while we're, doing it so that we can account for any swelling or kind of movement after you numb. The second thing I think is, and this is anecdotal, so we'll have to study it to really be sure, is I think it takes more filler in functional patients than in cosmetic, right? Either from scar or from just like synkinesis. If you're twitching your face constantly, then you're breaking down filler. So I actually think Botox or neurotoxin to stop the synkinesis makes my filler last longer. So I love the synergistic effect, okay? The other thing about synkinesis and scar is, so timing of Botox or neurotoxin is, as we know, around the mouth especially, you can do a lot with neurotoxin, mentalis dimpling, DAO muscle. Like you can do a lot of things to kind of make neurotoxin more symmetric in your muscle movement. So there are some patients that like fly in from somewhere or drive in from 3 hours. They come in, they get their Botox and filler on the same day because it's just logistically hard to do otherwise. But if it's not hard, if they are they don't mind taking off another time off work and come back in. I love when we can do filler after the Botox is optimized, because to me, Botox is the thing that really affects your movement, your like speech, the muscles, and the twitching. And so after the synkinesis is stabilized and optimized, now I can really look at a palette that is not moving, a moving target. So, and then one thing I never really realized until I was doing it more often is that lidocaine post injection, even that numbing, it's very traumatizing to someone who has had facial paralysis. So especially if you numb the side that is not affected, like the good side, quote unquote, some patients feel very like, oh my gosh, I feel numb and it's making my lip droop on the side. And it's very traumatizing, much more so than in a cosmetic patient where they're just happy it doesn't hurt. They know it's going to go away. So I warn people, especially if we're going to do the good side, I'm going to numb you and you'll have 1 to 3 hours of numbing where your face will be lopsided, not symmetric, and you will feel numb and you will hate it. And then even with that kind of description, some patients kind of, check out, go to the bathroom, look in the mirror, and then they come back and they say, is this normal? My lip feels lower. Is this normal? And we just have to reassure. And it always goes away. But that is something that I think is good to know ahead of time. And then the last thing that I think is really interesting is sometimes you look at a face and you have a facial paralysis side, and then you have a perfect side, right? So some patients feel they have a bad side and a good side. And sometimes you look at the patient and you say, I could actually put some filler on your good side to make it match more. I think some patients have a lot of synkinesis. So you keep twitching your mid face. And as a result, you actually have a great cheek on the paralyzed side. And then your other side will start to droop from normal aging. So we can actually put filler sometimes to make it more symmetric, but you're putting treatment on the normal side. So I think some patients don't want to make changes to the good side. They just don't want to touch it, don't want to risk anything. And it's important to know that, right? Because what you see as a third party or as a physician may not be what they want. And so I think to point it out and talk about it, look in a mirror. Sometimes it's helpful to look in a photo because you take your feeling out of the mirror and we look at a photo together and then you can decide. The good thing is if it's filler, it's temporary. So you can try it. And if you actually don't like it, you don't have to do it again. So there's some similarities between cosmetic and functional filler. One is neither are for everyone, right? So there's for select concerns. There's definitely people for cosmetic and for functional that come with like, I want filler here. And it won't actually make it better. Filler does not affect movement. It does not affect movement, as in dynamic things. It is different from Botox and neurotoxin. So it's important to know that neither are for everyone, right? And then just like with cosmetic, there are relative and absolute contraindications. Autoimmune disease, smoking, radiation, blood thinners, so many things where you're going to talk about the risk and decide you may have a different contraindication in your risk tolerance than even the physician or someone else. And so you're going to talk about it just with cosmetic and with functional filler. I think that filler, just like in Botox actually, and just like in cosmetic, it's a trial and error. So I always tell patients, I think of it like salt. You can always add, but you can't take it away. So, I mean, you can with hyaluronidase, but it's a huge waste of time and money and, effort. So it's always better to start low. This photo is like one of everyone's favorite photo of injectors is kind of understanding realistic expectations. So 5 syringes of filler is 1 teaspoon. So it's scary to patients, I think, when you say, I'm going to put 2 syringes of filler and they're picturing the overdone, blown out, kind of too fillered, puffy face. But you really think about what a syringe is. A syringe is 1/5 of a teaspoon. And so, sometimes not enough filler is actually, disappointing, but going slow is always an option. Okay. So the next steps is identifying who is the ideal candidate, right? Obviously, just like with Botox, just like with surgery, just like with anything, not every patient will benefit from filler, functional filler, right? So this is Dr. John Flynn. He's our awesome fellow here at Mass Eye and Ear and Harvard. He's going to present actually a talk at our academy meeting on who benefits more. Is it someone with more facial paralysis? Is it someone with milder facial paralysis? Eventually, we want to know, is it lips? Is it nasolabial folds? Is it eyes? Like, is it what severity? So I'm not going to say too much because we're still looking at it, but stay tuned because I think that is the next question in my mind is who is it? And also, what is the average volume that you need to inject to be able to really have a benefit? I don't think it's 26 syringes, but let's see, right? Our ultimate goal is we get insurance coverage for functional filler in the select patient. So identifying who that person is and showing, that how much it benefits really is key. So I think it's not an unrealistic goal to get insurance coverage for filler. So this is a different example, but it's really like such a similar idea in my mind. So this is a frontal sinus fracture. So right here, you get fractured, the bone of your forehead cracks in. And it doesn't affect your brain. It doesn't affect your certain ones. Anterior table frontal sinus fracture. Okay. You can see on the 3D skeleton that it just basically your bone crushes in. I'm going to show you a graphic image in a second. So if you don't want to see it, close your eyes for 1 second. This is a surgical photo, okay, of the defect that we're trying to fix. We pull the entire skin down of the forehead, expose the fracture, and put some tiny plates on it. And then in the end, that scar heals beautifully. We put the scar in your hair, and then in the end, all of that surgery, I'll get off of that slide, all of that surgery is to avoid having a dent in your forehead. If you say after that surgery, after that trauma, I don't really care. I will have a dent in my forehead. I don't care. I don't want surgery. You can go not have that surgery and live forever with really no functional deficit except for having a dent, right? So it's a very similar thing in that there is a surgical procedure, but actually you can put filler here if you wanted to. I mean, it's a different thing, but to me, it's just insurance coverage for a cosmetic or aesthetic concern that is a medical indication. So we know that for HIV lipodystrophy, it is now covered by insurance, right? So to me, the difference between like how we get there, I think they paved the road for insurance coverage. We have been studying how did they do it? Like there's a 40-page document. Number one, it started with, they showed a lot of studies that it helped, right? So we need a lot more studies. Number two, I think the pool of patients that are aware of this treatment and probably the pool of patients in general is smaller. So awareness is lower. There's a lot of patients that know about functional Botox, physical therapy, gracilis surgery, different kind of DAO little treatments. But a lot of people don't know that filler can be used functionally. So I think patients, referring providers don't know. So there's often people that, want to send, but they feel like it's cosmetic. I feel like it's not, but they don't even know that it can be kind of a functional benefit. And even surgeons, I feel like are learning the differences, how to do it. Like, I do think it is different than just going to the cosmetic injector and knowing the differences in the anatomy, understanding the differences in your muscle movement and kind of normal ways that you atrophy versus aging are really different. So I do feel like now we're training surgeons, everybody is going out. We have a fellow who just graduated and is at UCSD running a program. There's Dr. Kochar. There's a fellow last year, Matt Miller, who is now at Virginia. John Flynn will now be going back to, so there's just lots of people now going out, and there's going to be people everywhere that are making it more like available to people locally. And also now we're going to be able to do multi-institutional studies that really can be more powerful. So these are all our surgeons that are kind of learning how to do filler. And it's actually a interesting, it's much easier to teach someone filler than to teach someone surgery, I think. Because let's say you need 2 cc's of filler. You can do the first cc, I'll direct you, and then I will top off the last icing on the cake. Or I can move your hand. It's not a surgical technique where once you do it, if you don't do it right, you can't fix it. So it's actually much easier to train doing this than surgery. So it's just a lot of our trainees learning and then going out and being able to do this. So in conclusion, I think that filler can be an easy, life-changing treatment option for some people. Awareness is key. I love that CNN is highlighting it, and surgeons and publications, like, we're just becoming more focused on thinking of any techniques, whether they are traditionally thought of as cosmetic, to treat medical things. But I do think there's a difference. So if someone goes to just like cosmetic injector, they may be disappointed, right? Just like Botox is so different. You do 10 units for the crow's feet in aging, and you can do 30 units in facial paralysis. It's so different. So I feel like it's important to know the differences in techniques too. And just like with all things, having a discussion, having a two-way consultation. We have had people come in kind of seeing the CNN article and kind of expecting magic. And it's still filler, no matter what. It's not surgery. It's not, it's limited. So I think having a discussion and realistic expectations is really key. So thank you so much. This was awesome to be able to like have this, just thinking about it and talking about it. I love it. It's literally one of my favorite things to do. This is a picture of my kids social distancing, who are about to start school in 2 weeks. So, and I'm happy to take any questions. If anyone wants to reach out, feel free at any time.
Thanks, Linda. That was awesome. I can just tell from the way that you are speaking about this, how passionate you are about this topic. And, you and the team at Mass Eye are really kind of pushing the envelope on how we can really help patients. And I'm grateful, and I thank you for doing that and paving the way. I think one of the things is, our webinar is really geared towards patients, and the patients who are here, or the family members or caregivers of patients with facial paralysis who are here listening. I would also try to inspire you guys to all really go out and talk to your insurance companies and talk to your providers locally if they haven't already considered doing functional filler, to see if you can talk them into it. Because, and if they have questions, they can always reach out to Dr. Lee or to myself and ask questions about it to learn more. And I'm sure Linda would be happy to educate them as well on the topic if they had questions, and maybe give them some tips and tricks on how to see if we can get it covered as well.
I think with all procedures, I think it's going to be like somebody's family member has facial paralysis who is on, a politician who can then understand how much it can help people. Just getting the word out is so huge.
Yeah. There's a couple questions in the chat. If anybody else has questions, please put them into the chat and we'll go through all of them. The first question, Linda, is, does autoimmune disease affect functional filler? Have you seen that in your practice, maybe not just facial paralysis, but in general?
Yeah, it's a great question, actually. It's very controversial, and actually every injector will go through this in their own mind. So there is some literature. I think the most tricky thing is autoimmune disease affects everybody differently. So even in your own body, day to day, you'll have different effects, and different medications will help you. So there are some people that feel autoimmune disease is your own body attacking itself for an unknown reason. So then anything you put into your body, whether it's natural substance like filler, it's still a foreign body. And so there are some suggestions that you shouldn't inject filler into autoimmune disease. There are a lot of injectors that feel that's like not real. That's not an absolute contraindication. It's something to talk about and think about.
Okay, great. That's very helpful. Is it safe to do a filler functionally for somebody who's breastfeeding or pregnant?
Yeah, great question. So unlike neurotoxin, it's actually probably safer because there's not a neurotoxin entering. There is a little bit of lidocaine in each syringe that's automatically put in there. And so I think it is safe. But I actually, for my own patients, will have them double check with their pediatrician just to be sure. But I have not. There is actually a database on people who are breastfeeding and like what is safe and what is not in medications. And from what I remember, it's okay. But definitely check the up-to-date thing and check with your pediatrician.
Yeah, and just as a reminder, this is all opinion-based information, and this is not actual medical information that you can use to be treated. So always check with your doctor, provider, medical specialist before proceeding with any of these. And I would say, I mean, I think it was said in the talk, Dr. Lee mentioned it, for this type of sophisticated, more complicated filler, it would be wise to go to your doctor rather than going to a medical spa for your filler or your neurotoxin for this indication. Would you agree or disagree, Linda?
I think actually what surprised me is actually how different it is, even for, not necessarily that it's the doctor, but it's someone who treats a lot of facial paralysis, because
Yeah.
I think, the technique of actually injecting is the same, and the dangers and kind of the risks in some ways are very similar. But I think understanding patterns and, understanding, so it's for me, even it's so important to know the medical history. And like, there is a gracilis here, there is scar here, this is disuse, this is infection, makes a difference in where you're going to put your filler. So I think going to someone that's really going to understand the surgeries, understand facial paralysis in general, but then specifically know your history and anything pertinent in how it affected your anatomy is super important.
That's great. That's a great point. One question was, we talked about this previously too. Can you please, briefly discuss Botox for DAO? I know it wasn't a filler question, but maybe just give your thoughts on it and kind of just give some background, because I know it always comes up a lot now.
Yeah, it's a great question. Actually, where it's come up in our practice is if you have injury to the marginal mandibular nerve and you have a little bit of weakness and you kind of think it's going to come back surgically. So people will often send to us to get a little filler kind of to help them when they're waiting to recover. And then the other option is to get Botox to the opposite side to kind of make it match. So I think DAO in general, Botox is the great thing about Botox is it's reversible, right? It goes away whether you like it or not. So it's a good trial. 3 months can be a long time to not like something. So, you can use lidocaine, which is like a very short trial. It's not perfect, but it's definitely better than nothing. So you can try lidocaine, make sure you like it. And then if you like it, I think injecting it again can be amazing. But some people don't like it. Like, it may look more symmetric, but you've used your muscles to compensate and speaking. So it depends on whether you appreciate that. It may look better objectively, but you may not like the feeling. And then if you like the feeling and you are repeatedly doing Botox to weaken that muscle, you can resect it surgically. And so again, very carefully and with a lot of trial, knowing that you want that, it has been really amazing for a lot of patients.
Do you think that it works for patients with synkinesis too, or would you primarily focus it on patients who have marginal weakness from a prostatectomy or a facelift or something like that?
You mean filler?
The DAO Botox.
Oh, sorry. Your question is, what does it work for synkinesis?
Yeah, for patients with DAO activity from synkinetic movement as well. You mentioned
Yeah.
specifically for marginal nerve weakness.
Yeah. Yeah. I mean, I think if you think the synkinesis is related to the muscle, we treat the mentalis, we treat the DAO. So I think there's a little bit of trial and error to figure out where your specific concern is coming from. And I think you can't always tell with lidocaine because it's more diffuse. But I think sometimes you think it's one muscle and then you treat one muscle and then another muscle starts to overcompensate. So I think the great thing about Botox is seeing the same person over and over. So you can give that feedback. And to me, it's that salt analogy. Like, every time you do the recipe, it will be better. But you have to be able to like keep seeing the same person to get that feedback.
Great.
So I think it could help. Depends, I think.
A couple more questions. There's actually a bunch of questions flooding in now. Everybody is very, very complimentary and greatly appreciative of your talk. And so I'm, again, really grateful that you could join us. The one question was, how long after surgery would you say to wait before getting a filler injected? If somebody had a let's say they had a selective neurolysis, or let's say they had a, facelift on the other side, and,
Mhm.
their face is becoming more symmetric, but they still have some areas where they want to get treated, or maybe they had a 5/7, a masseter nerve transfer, or a gracilis. How long afterwards would you say it's okay to start thinking about getting filler?
Yeah, that's a great question. I think that the risk is really with scar. So you don't want to put filler into a scar bed because of vascularization issues. So if there's no great answer, I think some people will give it 3 months. And similarly with facelifts, actually, like
Yeah.
how long after facelift can you put cheek filler in? And I think if it's an area that is directly affected, like a actual scar, the incision line, or an area that is like close to the mouth or something like that, you might want to wait a little bit longer. But especially if it's healing, not directly under the incision, I would say maybe a few months would be okay. But also, you want to wait and let things kind of settle out. When you do filler, it can get swollen, can get a bruise, like all that stuff. So you want to not affect your healing. So it probably depends a little bit on what that surgery is and how long it takes you to heal.
Excellent, excellent points. You mentioned doing Botox first. How long after the Botox would you recommend doing the filler?
Yeah, great question. I think a lot of people's Botox takes on after like 3 or 4 days, but the general thinking is that after 2 weeks it's optimized. So I love it after 2 weeks, just because everybody will be done. You could probably do it sooner in some people, but safe to say 2 weeks.
Okay. And then there's a question about Botox for buccinator. Do you do that in your practice? And have you? I'm not really sure what the question is. It's saying, does the Botox for buccinator help with smile? I guess in your experience, what are your thoughts on that?
That I don't do. I don't know if others in the facial nerve center do, but I am not as versed on that. Good question.
I do a fair amount of Botox in the buccinator. I can handle that question. I typically don't use it to help with the smile. I notice that for patients who may be trying to smile, or when they're chewing, they'll get overactivity of the buccinator muscle. So that's typically why I inject there. It also just helps mostly to relieve a lot of tension in the midface. It's one of the best places I've found where you can really release some of that midfacial tension, because, as a lot of patients probably know, we can't really inject Botox in the middle, in the cheek region, because we could potentially cause a facial droop again. Um, but that actually leads into one of my questions. I have a few questions. So, are there any areas of the face that you can't treat? I mean, just like, Botox, we don't want to treat the central triangle, or the cheek of the face. Is there any region of the face that a patient should be a little very careful to have their
Yeah.
provider inject?
That's a great question. I For me, the risk of injecting filler into a blood vessel can lead to necrosis or things like that. So there's areas of the face that are higher risk and areas that are lower risk. So for me, injecting in the forehead has a higher risk of entering the ophthalmic system. So there's a tiny, really rare risk of blindness if you're injecting too close to the ophthalmic system. So I feel like injecting in the forehead, injecting around the eyes, you have to be much more careful. But there's some off-label uses of filler. The problem is all FDA uses of filler are for cosmetics. So, just like we do Botox in areas that are not FDA approved because it's a different issue. There's not areas that you cannot inject. It's more a
Okay.
kind of safety discussion with your provider, I think.
Okay, that's a great point. I think, if you're going to a doctor who's comfortable doing fillers, you should use their judgment based on where they would normally inject with a needle or a cannula, or where they may or may not inject, based on their experience and what the data supports and the safety of it. Because while it is a small risk for blindness, it is still a real risk, and it's something that you need to be very cognizant of and aware of, and make sure that your doctor knows how to handle that if it does happen, or your injector. Um, in terms of PRP, do you have any experience using PRP instead of filler, or as a surrogate for filler, or mixed with
Yeah,
fillers?
it's a great question. I use PRP a lot for hair loss. And I think there aren't enough studies yet, I think, for PRP with the filler to really know. So
Hmm.
I don't know of like any kind of objective differences. I know that filler is immediately visible. Like you're not waiting. So there's different, as you know, Sculptra or polylactic acid is a filler that you put in and then it disappears and then you kind of grow it. So you don't see it right away. But in general, all the hyaluronic acid fillers, you can see it. So as I'm doing it, I know exactly what is happening, which I think especially for the lip or for a small area that's very unforgiving, I feel like these hyaluronic acid fillers are better in my hands because I literally can just see what's happening versus PRP, which is a little bit based on growth factors and trying to generate it yourself. To me is less predictable. It may last longer and that would be great, but I don't think we know yet.
Okay, that's great. And this, this may be more for if there's any, anyone who watches the video that not necessarily a patient, but maybe a provider. There's certain fillers that we kind of think about better for the lips, better for the cheeks, in the cosmetic world. Does that change at all when you're dealing with a patient with facial paralysis? Because maybe they have a different type of anatomy. Would you want to use a thicker filler that you wouldn't normally use in a cosmetic patient in the lip, or a softer one, for instance, in the cheek? Does that ever weigh into your decision-making process?
Yeah, I think that's a great point. Because so many times people have surgical scars or the tissue is thinner or there's just differences in anatomy. So like you said, I think for the lip, I always feel better starting with at least the thinner one because I think you can always add. But there are times where you feel something and there's a little more resistance than in a aging face volume loss lip, and you need a little bit of a thicker filler. You have to be more careful, I think, with scar. So, the tendency to use a thicker filler also has to be weighed against the blood supply and things like that. So I think for all things, less is more, and start low, and then you can always kind of come back and add. But yeah, it's a great point. I think trial and error is a great thing about filler, that you can kind of do it just like with Botox. You kind of try this, I didn't like it, or this one was good, I want more in this area. So much about kind of figuring out your anatomy.
That's great. Well, I think that's all the questions we have. It's been about an hour. I am so grateful for you to join us. Thanks as always. You have been a great mentor and a great friend and colleague, and I'm just so grateful for you to share your time. And please say hi to all your colleagues back in Boston, and we look forward to seeing you hopefully in person sometime soon. And for anybody in the audience or who watches this video later, please reach out to Dr. Linda Lee, MD, and we will also share notes for the talk online. It'll be on our website, pacificneuroscience.org, as well, or pacificneuroscienceinstitute.org, as well as on our YouTube site. And if you have any questions, my email is in the chat, amit.kochar@providence.org. So again, thank you all for joining us. Thank you, Dr. Lee, for sharing your knowledge with us, and look forward to seeing you again soon in person.
Thank you.